Oh, thank you very much. It's great to be here. Over the next 15 minutes, John and I are just going to talk a bit about how we've been working very closely in partnership over the last few years, right across our health economy. First of all, just a bit of context for those of you who don't know who we are and where we are. We're three local authorities that make up the eastern end of London on the north side. So the river's running along the bottom of that picture, and the M25 is running around the outside of my borough, Havering. And I know you won't be able to read the details on that slide, but the important thing to know about it is that we're not three boroughs that are particularly easy bedfellows in terms of the needs that we have. We've actually got very different population needs. So Havering is a lot less deprived than either Barking and Dagenham or Redbridge, but actually we have the highest number of social care clients because we've got one of the oldest populations in London. Barking and Dagenham and Redbridge both have very young populations, whereas we have an older population. And our populations are growing at different rates, and we've got different diversity amongst us. So we are working across, we're not boroughs that are similar. We're boroughs with different individual challenges, but we do share the same health economy together. Our colleagues at NELFT, BHRUT and 3CCGs that work very closely together. And we have found that close partnership actually benefits all of our communities, no matter where they are in that patch or what their particular needs are. So I'm just going to talk for a minute about the Integrated Care Coalition and how it came together. Health provision, particularly people-centred, community-based health provision, has had a very patchy history in our area, and that's being nice about it, really. And certainly when I joined my local authority, we had a struggling acute service. We had too much money spent in institutions and in rehab beds. And there were and have until relatively recently constant headlines, particularly about our hospital, which is in special measures, and about individual mistakes that were being publicised. And against that background, it's actually very hard to have the conversation with the community about how they can take responsibility for their own health, because it's all too easy for them to be able to point at the paper and say, well, someone's letting me down here. We wouldn't be in this situation if it wasn't for them. Well, we decided about 4 years ago, collectively, the boroughs and all our health partners, that we just had enough, that we knew that we had huge assets in the system, loads of people with skills, people who were committed, they were absolutely working their socks off. But actually, we weren't getting anywhere because we weren't working in a single pathway, we weren't working together. We were therefore squandering some of those resources that Simon was talking about earlier, and actually literally pouring some of our money down the drain by not working cooperatively enough. So we faced up to that, and we decided to form the Integrated Care Coalition, which brought all the partners together. We decided that we would take a strategic approach and try to do things very differently. And the Integrated Care Coalition has allowed us to have a shared vision. It's been provided a catalyst for change, and it has allowed us to see some quite radical transformations within the system. It allowed us to have a single view on the 5-year strategic plan, and it's allowed us to drive a lot of change that we wouldn't otherwise be able to have done. But these things don't happen overnight. It's taken us a long time to get to know each other well enough and to trust each other well enough to be able to move forward, and John's going to talk a bit more about that later. This slide is a horrible slide. It just shows you how complex it is to bring everyone together. This is the governance structure of the Integrated Care Coalition. That's just the governance structure of all the partners that we bring together. Of course, if you drew lines for all the commissioning relationships and all the contracts that we had, you actually would just have a black piece of paper there because it would be so covered with lines. So it is very complex, and although we've made a lot of changes, which I'll give you a few examples about in a moment, we have actually reached a point where we feel that we need to make some kind of breakthrough through this this governance structure. We know that everyone has individual statutory responsibilities and decision making, and we honour that, but we also need to find a way to come together and work differently for the good of our communities, and that's why we're so keen to embrace the new opportunities that devolution offers to actually find different ways of cutting through those commissioning relationships and cutting through the complexity that we now deal with. So, I said earlier, change takes time, and this slide just kind of goes through some of the stages that we had to go through. Having made a commitment to each other, we had to take time in clearly understanding the challenges that we faced, and we decided that the best place that we could start was where a lot of the money we felt was being wasted around integrated care, particularly for those with the greatest frailty in the system. And we worked painstakingly through a business case for change, which justified taking a lot of rehab beds out of the system and therefore paid for some of the services that I'll tell you about in a moment. We then had to put a new infrastructure in place to deliver that and form up a load of new teams. Along the way, though, as we worked through this business case and we became more evidence-driven and we became closer as partners, we were able to take advantage of the things that were big opportunities in the system. For example, the Prime Minister's Challenge Fund brought us in a lot of money to experiment with new GP access hubs in the evening and on weekends, and new GP practices that focus on the 1,000 people that are the highest users of social care in the NHS locally. And more recently, we've become a vanguard for the urgent care pathway. So our partnership has now got into a virtuous spiral that we feel that we are able to present ourselves well and evidence what we're trying to achieve much, much more constructively than we did in the past. And that's, again, why we're so keen on taking the devolution agenda forward. So just to end my bit with giving you a few practical examples of the things that we've been able to achieve. We think that we've made a number of tangible differences for local people. I already mentioned the GP hubs at weekends and in the evening. A year or so ago, local people were saying they couldn't get doctor's appointments. They were having to wait for 10 days or 2 weeks. Now, if they phone directly or if they phone through 101, they are triaged and can get GP appointments within half an hour or an hour if they can get to those hubs within each of the boroughs. We've also got a lot of integrated teams working closely together, co-located in each borough, with workers allocated appropriately. Community treatment teams offer urgent treatment in the home, reducing the need for hospital admissions and A&E attendances. In my own borough, the new community treatment teams and intensive rehab teams have cared for more than 11,500 Havering patients in a little under 2 years. That means people didn't need to go to A&E, they didn't get admitted into hospital, they didn't leave their homes. Under the previous bed-based systems, we estimate that would have been more like 1,000 rather than the 11,500. We have a joint access and discharge team in place right across the system, and they plan discharge way ahead of time, and this has reduced delayed discharges of care. Again, in my own authority, our delayed discharges of care in October were 9. This is in contrast to August 2014, when the delayed discharges were 34. We have a falls car staffed by paramedic and nurses. They patrol the area between 7 and 7, and they respond to 999 calls about falls. And if they can, they give assistance and actually help and deal with that inside the home. So they, over the last year, have treated nearly 400 people who didn't have to go to A&E and who were able to be stabilised and helped in their home. Now, all of that has had a big impact on the system. In July 2005, BHRUT achieved its 4-hour A&E performance standard of 95% for the first time in 4 years, and that was a great cause for celebration amongst all the partners. In December 2014, it had been an achievement of only 76%. So you can see the kind of scale difference that actually trying to address the local needs at home where people can get help more successfully than going straight to A&E are really making a difference. They're just a few examples, but John's going to talk a bit more about the culture that sits behind that and where next.
Thank you, Cheryl. Good. One of the things I'd like to clarify, because I think it's symbolically important, when we talk about the coalition, we talk about healthcare providers, we talk about 3 local authorities, lots of other players, we talk about commissioners. The chair of the coalition is Cheryl, chief exec of one of those local authorities. That's quite significant symbolically, and it's worth perhaps a moment to think about. So Cheryl has talked about a lot of the challenges. So she suggested I'm going to talk a bit about culture. I will try and be brief. But I guess what we should remember is that invariably, when you look at very significant transactions, whether acquisitions, major change programs or whatever, it is invariably the soft systems that let them down. It's communication, it's the people systems, it's the culture. So for me, this is really critical. So my sense is that I need to think a bit about culture, and in some degree, I might make 1 or 2 comments about governance as well. But if we go back to when we started, we knew damn well we were in the wrong place. Something had to give in order to move us from where we were. And we knew that real integration was part of that solution. And it's an integration of physical health and mental health. It's an integration of health and social care, but significantly also it had to be a move away from dependence on hospital beds and trying to create different treatment and support solutions for people at home in their local communities. So we knew this was going to be really tough. I will share with you a little anecdote, but the thing for me that I start with is to think that trust is really hard fought, and it's absolutely critical that we move towards a position where we could achieve trust. But trust is difficult, culture is difficult, but so is reputation. So when you begin to think about some of these soft systems, we really did have a mountain to climb. I think Simon Stevens has gone, hasn't he? Yeah. Good, because I can't afford to burn any bridges. But he can't hear me. So there are 2 things. And the most significant thing is I actually pulled his sleeve one day. Didn't know who I was, so I wasn't terribly bothered. At the King's Fund, in fact. In the week that the 5-year plan first came out, I said, what are you talking about? This cultural thing. And really, in truth, if you look at the NHS and you think about the culture, it's quite authoritarian. It's quite top-down. A lot of command and control. I have been disciplined to be competitive, to compete in the market. The culture is very clear. And along comes this chap, Simon Stevens, talking about the 5-year plan, talking about collaboration, co-production, co-location. And it's almost, I said to him, it's the antithesis of the culture that we're working with. And that's how big the challenge was. And it's interesting because I have seen that discussion played out a lot. And I remember when the coalition first started, we had someone come and facilitate a group. And we were all in the room. There were 20 or 30 of us in the room. And the facilitator said, so what are the issues that we need to deal with? I put my hand up and I said, trust. That's exactly the same response we had back then. Complete silence and a shuffling of papers and awkwardness. So we have come a long way. And Cheryl's talked about some of the very practical things, but the magnitude of change was significant, and I think we've moved a very long way in terms of creating change behaviours. But the behaviours that were required to collaborate, to trust each other, to work together, they're very difficult. A lot of behaviour had to change. change. A lot of historical beliefs had to be suspended to take a brave step forward. And there are a number of things that come out of the woodwork along the way. And there are a few nuggets of real intelligence which I think are really important. I believe them. I hear other people occasionally talk about them, but I don't think they're widely reported. And one of the first ones is, you know what? External consultancy, expensive external consultancy doesn't buy votes. It very often generates a lot of resentment. But the interesting thing for us, and I think part of what we've learned, is homegrown and owned intelligence is the true currency of successful change. And that's been very significant. The interesting bit for us is that once we got over a lot of the difficult things, we learned to do some of the right things, we got over some of the kind of early hurdles, we started behaving differently, and not just disciplining ourselves to maintain that different behaviour, but supporting each other in maintaining that behaviour. Once we started doing those things, we began to experience success. And then it becomes a virtuous cycle. The future for us, I think, we certainly have a view that it is overwhelmingly positive. But we do know it's got to be very different to everything that we did in the past. And it has to be very different on a practical level too, because I think we would say we've exhausted the potential of the established systems of governance and control in terms of what they can deliver for us. And we need to move on to something very different. I'll just give you an example. As the chief exec of what is a pretty successful foundation trust, very often, if I sought to make an investment for the community, for the benefit of the community, which is our joint goal, it would probably not be consistent with my accountability to monitor. So a lot of the rules and regulations and governance that control FTs do not best serve the community. So you conclude from that, we actually have to get to a very different system of governance. And I've seen a lot of that in the press recently. So we embrace that opportunity into the future because we think the next generation of governance and change that will deliver those flexibilities and those opportunities for us will be an ACO. Thank you.